gonna go ahead and get started. Hi, everyone. Welcome to Women's Health Advocates Fertility Committee. We are thrilled to have you here. My name is Barb Calora. I am one of three co-chairs. We have Leah Chapman, who is also one of my fellow co-chairs here with us today. And Jessica Bell Vanderwall is our third co-chair. She is unfortunately unable to make it today, but she is the founder and CEO of a company called Frame Fertility. Leah, do you want to go ahead and introduce yourself? And it would be great if maybe you just shared what drew you to Women's Health Advocates.
Sure, yes. My name's Leah Chapman. It's so nice to see everybody and meet everybody. We're really excited for this call. I'm the founder and executive director of a 501(c)(3) nonprofit called the Women's Health Research and Action Center. We're based in Houston, Texas, and we primarily conduct research around women's health. Our specialty areas are historically overlooked conditions within women's health, including infertility, as well as pregnancy loss, endometriosis, and PMDD, premenstrual dysphoric disorder. All of us on the core RAC team, we abbreviate our nonprofit as RAC. All of us on the team have lived experience in one or more of these health conditions. So we're really passionate as researchers in improving the peer-reviewed literature on these topics. And we actually just got notified this morning that one of our papers on insurance coverage for IVF access was accepted for publication at the Journal of Women's Health. So very, very excited about that. The peer review process can take so long. So some good news to start out this morning. Excuse me, what drew me to Women's Health Advocates was just the incredible work and leadership that exists within this organization. It's just mind-blowing every time I go to an event, whether it's in person or virtual. They're just the most dynamic powerhouse group of leaders, and I'm honored to be a part of this and helping lead this committee with Barb and Jessica. So I'll leave it at that. And again, thank you for being here today.
Fantastic. Thank you so much. We kind of divided up the duties. So today is my day, and then I think the next meeting is Leah's, so she'll be running everything. But let me just start with, and I'll give a little background on myself in a minute. But let me just start with, we have a lot of people who are new to this committee, who are new to Women's Health Advocates on this call. So I want to do a couple of quick leveling things first. We need everybody to sign up for the Women's Health Advocates emails and all their correspondence. And you do that on the Women's Health Advocates website. Leah, if you could drop the website URL in the chat, I would so appreciate it. I was going to do that, but now I'm doing the slides and my screens are all messed up. But it's free. If you haven't already done it, please do so, like right now. Copy that link because some of us sent out the Zoom link before we knew the whole process. So you all did the right thing. We're the ones who messed up. I'll take the blame. But we would love to have you go to the Women's Health Advocates website and sign up. I heard about Women's Health Advocates early on, so probably last spring, 2025. And I think it was actually Leah's idea for this fertility committee. And so I was drawn to Women's Health Advocates because I loved the focus on policy. So really, when in the very simplest of terms, Women's Health Advocates is about educating lawmakers at the state and federal level about policies that impact the health of women. So we have so many things underneath that. And one of the ways that we've gotten people engaged is creation of these different committees. There are some that are based on health conditions, some that are based on things like reimbursement. Wow, that's exciting. And so forth. So we are new. We only have had one other meeting, Leah. It was a handful of us. I don't even remember who was on that first one, but we now have our act together. So, but bear with us because we are a new committee and the Women's Health Advocates, if you think about it, it's like exploded. And so there's a lot of processes and stuff that are being created to handle that explosion, which is fantastic. So great. Women's Health Advocates Fertility Committee. What are we going to do here on this fertility committee? First of all, we are going to make sure that the people who are part of this group know what's going on in the policy space at the federal and state level. And here's the thing. Interestingly enough, in the infertility, fertility space, there's quite a bit already being done by a lot of organizations. And we are not here to duplicate that. We are here to amplify their work and be additive. So, one of the things that Leah and Jessica and I are super excited about is to bring all those to you all. In our conversations with many of you, you didn't realize that somebody was doing something in Pennsylvania or in Michigan, or, that the military didn't have access to IVF and what's going on for that. So, again, that's a lot of what we're going to do. But we also want you all to tell us where you're seeing gaps, where you're seeing issues, problems, and maybe somebody's already working on it. Maybe somebody's not, right? So how can we as a group of people bring all these things up, but how can we also share what's going on out there so that you all can get engaged? And that's what is really exciting for all of us. So that's the purpose of the fertility committee. I shouldn't say don't. I don't anticipate that over the next, 6 or 8 months, we're going to come up with, a new bill that, Liz is going to introduce in Congress. I think we're going to figure out where those gaps are, but there's a lot going on already, and we want to make sure that you're fully engaged. Okay. I am so excited because when we put our content calendar together, we thought about starting not on a policy side, but on what is infertility. And I couldn't think of anyone better than Dr. Serena Chen to walk us through this. I don't even know how long I've known Dr. Chen. I don't know, close to 20 years probably. Um, I will tell you something about her that is super, super unique. And I am pretty confident that what I'm going to tell you is 100% factual. She is probably the first reproductive endocrinologist in the country who raised her hand to get involved in advocacy without knowing a lot about it and has been consistently involved day in and day out since the day she raised her hand. And I am so in awe of everything she does, and she's such an inspiration. And so she just said yes before I could barely even hit send on my text. And so she's going to do a level setting infertility 101. Look, for many of you on this call, you're going to be like, been there, done that. I could have given this talk, Barb. I get it. But we want to ground you in this. And then we're opening up for questions to Dr. Chen. You can certainly talk about other things, but I want to give you a preview. Our next call will be on September 3rd at 11:30 a.m. Eastern Time. We'll send out a calendar invite. And that's going to be where we get into some nitty-gritty about insurance, reimbursement in the IVF and fertility preservation space. You're going to have to put up with me. I'm going to be doing the talk, but something I know a lot about. And for those who don't know me, I was the president and CEO of Resolve, the National Infertility Association, for 18 years. I left a year ago. And if you know anything about any of the policy activities at the federal or state level in infertility over the last 23 years, I was probably involved. So that's really an area that's my wheelhouse. Breaking news, and then I'm going to turn it over to Dr. Chen. We had a couple things going on in the world, and this is where knowing about what infertility is, knowing what the treatments are, is so important when you do policy work. We have a lot of news in our field right now, but two things, and then Dr. Chen can share a third one that's hers, is the Texas Republican Party had their annual meeting where they get together and they come up with their party platform. And they did that recently. And guess what? One of the party platforms is in Texas for the Republican Party. Ban IVF. I don't know all the details, but obviously that is not good. Who actually follows the party platform, you may ask? I don't know, but I will tell you there were a lot of state lawmakers that were in the room when that was decided. So we certainly want to keep an eye on that and other things. And then a couple of days ago, we had the Department of Health and Human Services came out with grants that you can apply for. One of them is an embryo donation awareness program. It's been around at least 25 years. Resolve got some of those grants years ago. I was very involved, know all about these grants. However, when the grant announcement came out just in the last week, it referred to embryos as children over and over and over in the grant announcement. So why does that matter? You're going to hear from Dr. Chen why that matters. So I want you to know that understanding what infertility is, understanding the treatments, helps you better advocate and better follow policy. Leah was just telling me about some statistics around do people really even know what IVF is?
Mhm.
I can tell you, and this is what I replied back to her, most lawmakers do not know what it is. And I think any of you who've ever talked and advocated in this space, I see Julie, of course, Dr. Chen, you know that to be true. So, without any further ado, Dr. Serena Chen, we are honored and grateful to have you here. And I'm going to run the slides and turn it over to you.
I think you are muted,
Oh,
Serena.
still on mute. Yeah.
Muted. Okay. Can you hear me?
Do you know how to use Zoom? There's a little mute, unmute, just making sure.
I always forget. Okay, let's go to the next slide. Infertility 101. Let's do this. So, on the left is that's my video. I'm trying to get to over 2 million views because my brother just got to 3 million on his thing. So we're in a competition. I think you will enjoy the video, so please watch it. A lot of common questions from the internet that I answer. I am on a couple advisory boards. I put these specific websites up because I just when I saw WHA and Barb asked me to talk, I was so excited because I looked at the organization and it looks amazing and I'm just so excited to be here. And these are two other organizations that are they're they're your peeps also. 51and.com and letstalkwellwoman.org. Letstalkwellwoman.org right now is more of like kind of a Northeast Coast thing, but doing some really amazing things, education awareness, 51 and education awareness policy, just trying to fix women's health care. So I think we're all speaking the same language, and I would love for you to check out those websites and get connected and just, get on the email list and things like that. Right. I just stepped down as the division director of reproductive endocrinology and infertility at the Cooperman Barnabas Medical Center, where I did that for like, I don't know, a couple decades. I am currently the director of advocacy at CCRM New Jersey, and I am a Rutgers clinical associate professor. These are my disclosures. I do some medical advising and speakers bureaus and things like that. Next slide. And this is my group. I think they're amazing and wonderful. And without these people, without their support, I never would have been able to take the time to do advocacy. In fact, I just got a call today to testify for a bill for Monday, which is actually a lot of notice for a lot of these hearings. And Dr. Hughes, who's on the right with the blonde hair and the leopard print, said, "Okay, I'll cover you for that day." So, a really amazing doctors if you're in New Jersey and you need, some fertility help. These are the people to call. Next slide. Okay, so these are the things we're going to go through. Definition, diagnosis, prevention, treatment, hope, present and future challenge. I am going to go quick because I do think, many of you probably have some awareness of a lot of these things already, and this will be review for you, and I would love to hear any questions that you have. Next slide. Okay, so this is basically it. Reproduction. Um, this is obviously why I didn't become a professional artist. This is not drawn to scale. We need an egg, we need a sperm, we need a uterus, and then we get a baby. But this is important to keep this in mind. Like, this is basically what we're talking about. Next slide. Okay, so right now, this is a definition of infertility, and this is very apropos because this is the definition that most legislators I am seeing are using when they're writing bills, because this is the definition that has been around for decades and decades. No baby after 6 to 12 months of unprotected intercourse. And those of you who deal in the infertility space every day know that this is a very limited, heteronormative, cisgender definition. But this is all the data that we have, okay? All the data we have, and we don't have that much data because, you know, earlier somebody was saying, well, we concentrate, or Leah, you were saying we concentrate on areas of women's health that have been ignored. And I feel like it's what area of women's health has not been ignored? It's like the whole shebang, right? So this is very cisgender, it's very heteronormative, it's very limited. It does not follow the current ASRM guidelines. I believe the WHO is still stuck in the patriarchy and they still use this as their official definition of infertility. But for those of us in the United States with ASRM that are at the leading edge of fertility care, this does not, this is biased against people who don't have a partner for our LGBTQ patients, things like that. So this clearly goes against ASRM ethical guidelines. Do not restrict care based upon partner status or sexual orientation or sexual identity. Okay, so that's the problem with this current definition. And just yesterday, I got an email from one of our lobbyists saying, "Hey, this bill is before, the New Jersey Senate, and they have this is the definition of infertility in one sentence." And then like two sentences later, they're like, none of this bill should be used to discriminate based upon partner status or sexual orientation or sexual identity. And I'm like, well, if you use that definition, United is definitely going to restrict care based upon sexual orientation, partner status, and identity, because that's what they're doing right now. Next slide. Okay, so basically, the current ASRM definition is if you can't get pregnant for whatever reason, be it medical, physical, social, logistical, if you need assistance and fertility technology, fertility medicine can help you, you should have access to that treatment. So that's the current definition of infertility. I'm probably butchering the wording. I'm sure they say it in a much more eloquent way, but that's basically the bottom line. And, Barb and I have worked on bills and things like that, and there is model legislation, and some of the newer mandates include that new definition for infertility, which ASRM just really adopted, I think, just in 2022, 2023. So a lot of people are not up to speed on that. And of course, we do really lack data, like all the data on single people and LGBTQ is extrapolated. So there are so many other things, like, of course, 6 to 12 months of unprotected intercourse, 6 months if you're 35 and up, 12 months if you're less than that, is one definition for infertility. But what if you can't have intercourse? What if your periods are irregular? What if there's no partner? What if you're LGBTQ? What if you have endometriosis or PCOS or the new now called polyendocrine metabolic ovarian syndrome, PMOS, POI, premature ovarian insufficiency, used to be known as premature menopause, but now is a much wider definition, not including just menopause, but ovarian dysfunction. What if you have cancer? What if you have, Crohn's disease or other chronic conditions? What if you had surgery in your reproductive tract? What if you didn't have any of those things, but you have a partner history of those things or your family history of those things? All of those are risk factors. What if you and your partner both carry some genetic disorder? All of those things should be considered under the umbrella of infertility. And so, next slide. So those are common misconceptions about conception. And one of the most common things with even that basic heteronormative definition is that people feel like they have to try really hard to get pregnant. But, the minute you stop using condoms, birth control pill, the IUD is pulled out, you stop withdrawing, that's the beginning of your fertility journey. It should just happen within 6 to 12 months, as long as you're not actively trying to prevent pregnancy. So, and that's a misconception we see all the time, and it causes significant harm because many people come to us very late in their journey, and that makes it harder for us to help you get pregnant. Next slide. Okay, so the diagnosis, it's really basic. Like a lot of the stuff we do, very little is new. Like the HSG was invented in the 1800s, and basically most places are still doing like the same version of this test that was invented in the 1800s. Pelvic sonogram, now is good because sonograms are getting more and more snazzy and really advanced, and more general OBGYNs have pelvic sonogram machines in their office. So we consider that part of the physical exam. The history is super important because, as we just discussed in the previous slide, you know, what if you don't have regular periods? Then you need to go to treatment and evaluation right away. We don't give you 6 to 12 months to try with your irregular periods. Semen analysis is important. Usually we give the guys 2 or 3 times to, give us a good sample. So we don't make a diagnosis based on one single sample. And then there's blood work. And not everybody agrees on all this blood work, but this is what I see most programs in the United States are doing. We do general health testing. We do genetic testing, extended carrier screening on everybody, where we look for mutations that don't affect the parents but could potentially affect the baby. And the AMH, anti-Mullerian hormone, is that one test that tells us about ovarian reserve, which can be so critical in terms of predicting prognosis for success with fertility treatment. So that's a general overview. It's not a ton of testing, and it definitely can be done by general practitioners and your general OBGYN if they, take the time to do it. And that little picture in the corner is a normal HSG, where we actually inject dye into the uterus and out the tubes, called a hysterosalpingogram. So hystero means uterus and salpingo means tubes, and gram means picture. And then we take an X-ray and see that the uterus and tubes hopefully look good. Next slide. Okay, so um, I just thought this was a cute cartoon. Okay, next slide. Prevention. I think prevention of fertility is something we should all talk about and we should all be aware of. And every young woman should understand and know, and every physician should be able to help their patient with this. But currently, this is not at all part of our healthcare system. Um, as you know, I, hope women's health advocates will take this up. Right now we're dealing with lack of coverage for disease, but bundled up into that, we should also be talking about prevention because, as we know, the cost of healthcare is totally out of control. And one of the reasons for that is because we are not really a healthcare system, we're really a disease care system. And it would be good to become a healthcare system where we actually um, improve people's health and prevent disease. So right now, that's not part of our healthcare system. And that could include things like, just counseling about stopping smoking and diet and avoiding toxins and regulating periods during PCOS and addressing painful periods and diagnosing endometriosis early. So prevention can look like a lot of different things. And basically, as a system, we're just failing at this. And yet, I think this is the key to fixing our broken healthcare system and preventing the country from going bankrupt against our currently rising healthcare costs. Next slide. Okay, so treatments, obviously we want to address abnormalities. We're not so good at addressing abnormalities. Like and this points to, I think, the lack of funding and research and knowledge in women's healthcare. Like, we don't know how to cure endometriosis. We barely know how to diagnose it. And once somebody already has all this damage in their pelvis from endometriosis, surgery can be helpful, but it does not really cure it. And surgery often is not adequate to address like serious tubal damage. And a lot of times we just have to work around it with our fertility treatments like IVF. We do want to optimize general health. General health often is not enough to get people pregnant, but it really lays a platform for helping these treatments be successful. Um, the best example of addressing abnormalities is PMOS, or PCOS, where somebody is not ovulating, and if we can get them to ovulate, then literally boom, we can often have a baby. Age is obviously a big issue, and that brings in all kinds of societal issues. Why is it that all our young people are depressed and anxious and feel like there's no hope for the future and therefore uh, are not producing enough babies? Um, you know, Gender pay gap, people are delaying childbearing. Egg freezing is one thing that can help mitigate that risk, but it is not the solution. And, that's a big one, and we haven't figured out how to solve that one. Obesity, we're still dealing with the obesity crisis. We are very excited about GLP-1s. They do seem to be making a significant difference, but they have their own issues that we have to deal with. But a lot of times, just losing the weight for some patients can be enough. But so many of the people I see are in this very intellectually frustrating, but still good prognosis category of unexplained. And usually that's kind of an age you just harder to get pregnant as you get older. And most people start trying to get pregnant, in their mid to late 30s. And stage 1 to 2 endometriosis, which is very difficult to diagnose. The only standard way we have of diagnosis, the only super reliable way we have to diagnosis these days is we got to make a hole in your belly, put you to sleep, anesthesia, make a hole in your belly, look around with a laparoscope and take biopsies. And then we can diagnose stage 1 to 2 endometriosis. And that study has been done in the past. So we don't do that now to our patients. We just say, yeah, everything looks good. There's a 50 to 70% chance that you have stage 1 or 2 endometriosis. And that might be the explanation for your unexplained infertility. And of course, our treatments, we don't have a huge suite of treatments. Clomid for anovulatory people, Clomid IUI or letrozole IUI for young people with unexplained infertility or mild endometriosis. And then, of course, IVF um, can address not just tubal infertility, but all kinds of different infertility and recurrent pregnancy loss and genetic disorders. And then for serious cases, sometimes we need things like donor sperm, donor egg, and gestational carrier. And each of these things we could talk about for hours, but we're not going to do that. Next slide. So this is back to that picture. I just want people to see what IUI is. There we go. So this is intrauterine insemination. It's kind of like a pap smear. It looks scary because the woman's sliced in half, but it's really not. It takes like a second, and usually for most of our patients, we're giving them a little Clomid or letrozole, and then we're doing IUI. And we do this for unexplained infertility. And we don't, patients are always like, but we're having intercourse twice a week, and the sperm looks okay, and the tubes are open. How is this going to help? And if anybody tells you they know why, they're lying to you. We don't know why. We don't know why this works. But we have hundreds and hundreds and hundreds of studies done all over the world globally that demonstrates that Clomid IUI, for whatever reason, in unexplained infertility, does significantly raise the fecundity rate to almost normal, which is 5 to 15% per cycle. So we do a lot of this, especially in young people. This can be a reasonable place to start. Next slide. Um, and this is just a slide of where normal fertilization takes place, and I wanted to show you the in advance of IVF. This is called in normal fertilization or in vivo fertilization because it takes place inside the body. In vitro fertilization or IVF just means fertilization outside the body. So this process of where the sperm meets the egg and the little embryo grows and travels down the fallopian tube instead of occurring inside the body is occurring in the IVF lab. Next slide. Oh, my slides are kind of out of order. Anyway, this is show a bunch of sperm, and there's one sperm carrying a bottle of wine and a bunch of flowers. And one of his fellow sperm is like, good idea, guy. Very clever. Okay, next slide. Because there's millions of sperm and only one of them is going to win. How does that work? So this is the IVF process. We can you guys see my little arrow or not really? Maybe only I can see it.
I can see like blue arrows on the slide, but I don't
Okay,
see.
but you don't see my arrow that I'm moving around. Yeah, that's probably only on my slide. Okay, so at the bottom left corner is the egg aspiration. That is done under anesthesia, and the patient should be fully asleep. There are still some pagans out there that where the woman is half awake and uncomfortable, and that's really a bad thing. And I think if, you're at a place where they're torturing you to death with that, you should go someplace else. So anyway, we do this under anesthesia. It's not a full surgery. It's a needle about the same size as the blood drawing needle, but it is long because we have to reach to the top of the vagina. And it just goes through this 2 millimeters of tissue at the top of the vagina because the ovaries, once they're stimulated with the drugs, is right there on top of the vagina. So very, very easy. We see the whole thing under ultrasound. And when you're totally asleep, it's really not that much more complicated than drawing blood. But because, we're going through the vagina, the needle is entering the body, we do put you under anesthesia. And it's literally a 10-minute procedure. So you get the IV, you go to sleep, 5 minutes for the right ovary, 5 minutes for the left ovary, boom, you're done. Eggs are in the lab. Now we put them in a petri dish, we put them together with the sperm, we let them incubate, we let the embryos grow, and then maybe we do some testing, or maybe we don't, maybe we freeze them, maybe we don't. Most programs in the United States right now are doing freezing and testing of the embryos. And then once we get a great embryo, we thaw it and put it in the uterus at the right time of your cycle so that you get pregnant. That's the bottom right corner. So the embryo transfer procedure, very similar to what I just showed you with the IUI procedure. It's like a pap smear. You're awake, we put in the speculum, we have this super soft catheter, it goes in. It's even for many patients less uncomfortable than the pap smear because the catheter is so soft. The part that's less uncomfortable, that's more uncomfortable than the pap smear, is that usually your bladder is half full. And the reason we do that is because we usually do an ultrasound, and the half full bladder allows us to visualize the uterus and the catheter under ultrasound so we can see exactly where the catheter is and we can put it precisely in a good spot. And that is super quick. So we put the embryo into the uterus. You're often on medications. We cross our fingers. Usually 11 days later, we are then checking a pregnancy test, and hopefully you're pregnant. Next slide.
Before I move on, I
Yeah.
want everyone to notice in the bottom right, it says embryo transfer. From here on out, every article, every time you see anything in the media about IVF, I want you to count how many times they say implant as opposed to transfer. So people mistakenly, especially in the media, say the doctors implanted 3 embryos. The doctors implanted an embryo. Dr. Chen cannot implant an embryo.
Yeah, only the
It,
embryo can do that.
it is literally transferring from one place to another. So it's a pet peeve of mine. I can't wait for you guys now to look at news articles and go, there it is, implant. It's never implanted.
Yeah. No,
Anyway,
that's a really good point, Barb. I didn't even think about that. I use points that Barb makes all the time. Just make a note of that because that's going to come in handy because everything she says definitely comes in handy later. So, that I didn't even think about that, Barb. That's a good point. Okay, this is one of our embryologists. Look at this table. She's got the embryo up on the screen. That embryo is magnified, I don't know, 500 times or something. You cannot see the embryo with a naked eye. That is a stage day 3 embryo. It's at the stage where all the cells are very similar. And she's sitting in front of a microscope, and this microscope has these, I don't know if you see those skinny things coming in. Those are little mechanical arms. It's called a micro manipulator. So it translates her movements into micron movements. So she's literally can do microsurgery on the embryo. And the table that she's sitting at is a very special table that absorbs all vibrations. So when I march into the lab, I'm not going to mess up her microsurgery because this table absorbs all those little tiny vibrations from the whole building, the whole room, so that she can safely do microsurgery on this little teeny tiny embryo. Next slide. So here are some even higher res pictures. This is on the left is a glass pipette that is literally picking up a single sperm. Sperm are the smallest cell in the body, one of the smallest cells in the body, and eggs are one of the largest cells in the body because eggs do all the work in the beginning of the embryo's life. And the sperm does nothing other than just deliver the DNA. So it is a DNA delivery machine. And the egg has to do all the work in the beginning, feeding the little embryo, growing, dividing, bringing snacks and an extra change of clothing. And the sperm just delivers the DNA. And then eventually, after day 3, the embryonic genome, including the sperm and egg DNA, will start making proteins and mRNA and contributing to the growth of the embryo. But those first 3 days, all up to the egg. So the middle picture shows a holding pipette. So that's literally using a teeny tiny bit of suction to hold the egg. And there's like kind of zona around the egg. That little circle around the egg is called the zona, and the pipette is piercing the egg. That's how we do ICSI, where we actually pierce the egg and we just stick it with a needle and jam that sperm in there. And this revolutionized male fertility back in the 1990s, where we were struggling. We had all this sperm and these eggs, and we stick them right together. And when you have male factor infertility, you could stick them together and nothing would happen until somebody accidentally, their hand slipped, they jammed the sperm in, and voila, we solved 99.9% of all male infertility. So that's a very interesting little thing in history. The bottom right is a picture of an embryo around day 5, the blastocyst stage. So that embryo, unlike the day 3 embryo that you saw before, has like 100, 200 cells and has now differentiated. That previous embryo, each cell was about the same, but these cells have all made some decisions. Some cells have decided to become the placenta. Some cells have decided to become the baby. And because of that differentiation, we can now take some cells from the part that's decided to become the placenta, leave the baby part alone, and take those cells and analyze them and figure out, are there a normal number of chromosomes? Does this embryo carry cystic fibrosis? All kinds of cool things like that, as well as some other things that, you know, we're not totally sure we want to know yet, like how tall is the embryo going to be? How smart is the embryo going to be? Those kinds of things. Next slide. Okay, so when the REI gets involved, sometimes that simple picture I showed you before can look like this. It could get really complicated. So when we have this is a picture of basically of what we call third party reproduction, where instead of just The man gives the sperm, the woman gives the egg, the woman also carries the embryo and the baby. We have other people involved, like a sperm donor, an egg donor, a gestational carrier, or gestational surrogate. When you have those things involved, then you need the REI doctor, but you also need a psychologist and you also need a lawyer. And, and you also need a sperm bank, and then you might need an egg bank, and you might need a surrogate agency. So, and then of course, there are the two people who want to become parents, and we call them intended parents in this scenario. So it can get really crazy and complicated. And this is where, like, a lot of the laws in this country involving Roe v. Wade have really impacted REIs in this country in terms of our ability to help people get pregnant, is because uh, the whole Dobbs decision has allowed passage of laws that can really mess with not only third-party reproduction, but of course IVF. Next slide.
Um, Two things. First of
Yeah.
all, do y'all see she's got like a fried egg there for the egg? I'm just like, that's what it looks like. I'm just cracking up about that. But I think this is a really important slide, and I want you all to remember this slide and what I'm about to say. There is now advocacy organizations representing pretty much all the facets of this. Of course, we have patients, we have physicians, we've got agencies, we've got lawyers. Just a few years ago, we have donor conceived advocacy groups.
That just started. So we
And
always had the baby on the side. Yeah, the baby, as long as it's healthy,
yeah, and
nobody does anything else. But now these children are standing up and speaking for themselves.
are adults and talking about it. And then very recently, this is kind of breaking news, there's going to be a new organization representing surrogates, advocacy organization. So it's really interesting to see how your picture here, we have different representations of different voices, different perspectives, and it's really exciting to see happen.
Yes, and actually, Israel already lost a lawsuit against donors, right? In terms of the money they're
Egg
paid. But
donors.
there's so many interesting questions that
Yeah.
come up with all of these things, and this is a U.S. version because there are many countries in which most countries around the world actually surrogacy is illegal, which is why we see a lot of countries working on things like uterine transplantation. So inability to reproduce, this is something that like I just don't understand. And you know, reproduction is so basic, right? Like as a human race, we would not exist without the ability to reproduce. And yet disorders and barriers to reproduction are just, you know, not given any consideration in our healthcare system at all. So, and this obviously brings in policy, and this is why things like reimbursement and CMS and things like that are boring but become so essential because reproductive disorders are not considered, the treatment of reproductive disorders are not considered essential healthcare. So,
Dr. Chen,
and
you've got like 3 more minutes, and I know
okay,
you only have like
I
two
have one more
slides.
slide, I think. That's
Yeah.
it. Or maybe two more slides. I don't know. One
Yeah.
more slide. Okay, so these are all things I think, Barb, you guys are planning to talk about in the future in much greater detail. But this is not science fiction. Like you can see some of these things, stem cells, gene editing, PGTP, polygenic gene testing of embryos, looking at embryos for height and eye color and intelligence and things like that. Artificial wombs, literally growing a baby inside a Ziploc bag. This is starting to happen right now. Scientists are working on it right now. Companies are forming to do these things. And we as a society, and especially as a group of people who are interested in policy, we really need to get involved. We need to understand these things. We need to stay aware so we can stay ahead of the curve, educate everyone, and try to make, the right decisions instead of creating some crazy, eugenic dystopian future. Okay. So that's because like this is this bottom line on the right. I can totally see United doing this. Will United decline care for your baby because you should not have had a baby with cystic fibrosis? Because that can be prevented. Right now they're not covering it, but next thing you know, they're going to cover it and they're going to use it as a cause to deny care. That is their pattern of behavior. I'm sorry if anybody works for United here. I apologize. But
You've used them twice now. I wonder
I
you have
have.
a
I'm like,
deep-seated.
I'm mad at them right now.
You're mad at United Healthcare. All
I'm mad
right.
at them.
You
Okay.
are right. That was your last slide, but everybody, please look at her, how to find her. I love how you started this off. You're in competition with your brother on followers. So we want you to win. You're a winner. By the way, huge applause for Dr. Chen. Could we all just sit here for the next like 2 hours and listen to her? Yes. And and now you know why we all ask her to testify because she's amazing and explains it in an amazing way that I am just like you're on the edge of her seat. So we have a few minutes. We want to open this up. Raise your hand, just go off mute. I did get one question that came in advance for somebody who's not here. And so just going to quickly do that. It's not anything that you touched on, but in a way it does. But it's talking about the shortage of your colleagues,
Oh
reproductive
my God.
endocrinologists, right? And because you're a subspecialty of an OBGYN, we won't go into all of that. But in a nutshell, if you can, how does that shortage of those specialists impact, the perhaps patients get
Yeah,
delayed,
it's crazy. It's crazy. It's a real problem. It's a huge opportunity though for biotech, some biotech solutions, I do think. And if you listen to David Sable, like I think he's got some ideas, but like I'm kind of pissed at ABOG, American Board of OBGYN, because they're like up there in their ivory tower and they're like being like, no. OBGYNs should not do egg retrievals, nor should nurse practitioners, nor should PAs. But by the way, we only train like 35 to 50 REIs a year, and there's
per
like
year,
per
30
year, and
to 45
there's
people
1,300 of us, and even if we only look at the heterosexual people, 1 in 6, 30 million people are affected by infertility, and 1,300 of us are supposed to help them. This does not add up. It does not add up. So ABOG needs to get out of their ivory tower and come up with some solutions instead of just complaining about this. I like Louisiana, like half of the state is a complete healthcare desert. If some dude is like willing to like learn how to do egg retrievals and help people get pregnant, we should probably support that and figure out how to make it safe and reasonable for patients. So are some of these people, some of these programs that are training OBGYNs, is it maybe a money grab? Yeah, maybe it is. There's that aspect to everything that we do, but there's also a good aspect, and there is an access problem. It's a huge issue.
Yeah. I want to just again we'll talk about the policy side in future meetings. So feel free to ask any questions now of Dr. Chen and about the process. Wow, you brought up some amazing things at the end there about things to think about into the future. I loved your emphasis on prevention, and thank you because I've already written that down, Leah, as a gap. I know a lot of people on this call do a lot of policy work and advocacy in this space, and there's just not a lot of attention being put to prevention. I can say that with confidence. So thank you for that. So Leah, do we have any questions in the chat?
No questions in the chat, but it looks like Julie has her hand raised.
Okay,
Julie, do you want to come off
Julie.
mute?
Oh, nope, she doesn't. She's looking at me going, no.
No, oh, sorry, Julie Martyr.
Julie Martyr. Sorry.
Oh, and she just put her question in the chat.
Hi.
Go
So
ahead.
sorry. I was trying to come off mute and type at the same time and accidentally said my question or part of it. But anyways, thank you. This is absolutely incredible. I would love to hear your thoughts on what we as a society could possibly do with the vast number of frozen embryos that don't have a very good fate ahead of them. Because, for example, I guess I can speak from my own experience. I would have loved to have been able to donate our embryos to some really purposeful scientific research, something that would help people, because I view the embryos as such a precious, um, you know, I don't even know what they are, but they're precious, and they hold all sorts of information that brilliant scientists like you, Dr. Chen, could probably solve
Yeah.
important
Yeah.
problems for humans
Yeah.
using. But there's nowhere to do that.
There's
So
so many
if the
barriers.
embryos they can't be donated to science, and if we don't want to have more children, and we're not comfortable creating children that are ours but that aren't, throwing them away feels so tragic.
Yes.
What do we do? And it also feels
They
like a
can,
completely inefficient.
this
Great.
is a good question. They can be donated to science, but maybe your program does not have the facility or the resources to be able to do that because, as you know, any embryo research has zero funding. And all funding with embryonic research has to be private. And the private sector, of course, they need to make some money. And so supporting scientific research in this area is really, 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 really challenging. But that's a great question. Where are your embryos? Because I'm going to talk to like some company. I just wonder
Please,
if they have some sort of program
Yeah.
to
please.
like take your
We're
embryos.
we're at Northwestern University,
Okay.
Okay.
and
We
they
we
do
wrote
have.
we got a couple other questions and I want to get to those.
Oh, sure.
We wrote that down. We're going to come back to that in a future call. I love it. Thank you. Sherry, you were next and then we'll go to
Thank you.
Risa.
Yeah, well, two things. One, are you going to maybe share the other people's information and bios? I mean, I'm sure there's a wealth of information on this call. I'd love to get connected with folks. That's just one. But the other one was, it seems to me that there's a massive education gap around fertility awareness. And this is one of the areas I'm really passionate about. When you talked, it was really something to me when you were talking about we treat diseases, but we really don't look at prevention. Is there anything, policy wise or recommendations about what younger adults should be learning about fertility? Because what they learn about is pregnancy, abstinence, contraception, STDs. We send them out into the world with no meaningful information around reproductive timelines unless they seek it out themselves. So this is a real hot button for me. I'm speaking at universities about it. I'd just be interested to know from a medical opinion or from the group's opinion around policy, if that's something that really should be considered.
I think so. Absolutely. I think it is getting better. I think these younger generations are talking more. A lot of it is amongst themselves because there are no specific programs. And of course, we're banning sex education across a lot of countries, a lot of the country. So we're kind of going backwards. We're kind of like at this weird dichotomy of incredible science and innovation, and then the dark ages, on the other hand, some of this legislation. So it is definitely something I think hopefully this committee will work on because I do believe that's one of the biggest gaps in healthcare is the lack of information and education, not just for patients, but even amongst physicians and healthcare policymakers. So we have a lot of work to do. Yes.
Quick, and we're going to go to Risa and Stephanie. Hold on, Risa. I see people already doing it. Yes, put your LinkedIn profile link, put your contact information if you want to put an email. We'd love for you to put in the chat. I should have said that at the very beginning. So Sherry, thank you for that reminder. Risa, my good friend.
Hi, Risa.
Hi, Serena. I put this in the chat earlier, but I guess it got missed. You talked about HSG for a moment there. Why are HSGs still unmedicated? Why is there no anesthesia? Why are there no painkillers?
Okay. This is like
Endometrial biopsies.
it's a weird thing in healthcare. And I'm trying to solve it here in New Jersey, but it's very, very difficult. Most HSGs are done by radiologists, okay? And radiologists became radiologists because they don't like to touch people, okay? They like to sit in the dark and look at pictures. And then you take these radiologists and you force them between the legs of a woman and make them do a pelvic exam, and they have no effing idea how to do that. So they're just completely lost. And we are in a state of New Jersey where we have maybe one or two radiologists who do HSGs on a regular basis. So we had to build an HSG suite, and our nurse practitioner is overwhelmed because she like day and night, can't do enough HSGs. I usually, usually some Advil, some Valium can be helpful. Sometimes people use a lidocaine spray. Um, and then there is also this historic tradition of not medicating women for most GYN procedures like IUD insertion, HSG,
Conventional
cervical
diaphragm.
biopsy, childbirth, things like that. It's like a mindset that we have and a tradition we have in the
Wow.
healthcare system that is starting to change, but we
Wow.
need to make some progress on that.
Super interesting, Risa. Thank you for that. Stephanie, hi. Good to see you.
Hi, I was here just on camera off. One thing, and hearing from Dr. Chen, I always love hearing her speak, and you're totally right, Barb. Always an engaging speaker and share such very important information. One thing to think about as we, talk about prevention, which I completely agree with, is obviously making sure that we're not feeding into the RM discussion, right? From
Very
the
good point.
ranges. RM is in essence they're infiltrating it by way of prevention, which we're seeing it across the country in multiple state houses. They're basically saying that this is why we should be validating this made up medical term called restorative reproductive medicine that's made up by the Heritage Foundation and now being
Okay,
advanced.
so RRM is
Anyway,
not made up by the Heritage Foundation. It is a legitimate viewpoint for religious concerns, but it has been legislatively weaponized by the Heritage Foundation in order to shut down IVF. One method of trying to shut down IVF. So it is difficult because there are some people who are truly trying to address the legitimate religious concerns of patients, which all of us reproductive endocrinologists try to address on an individual one-on-one basis. But you're right, Heritage Foundation is weaponizing it. They're very organized. Their marketing and their messaging is great. And it's a problem because when I talk about prevention and root causes, these are like buzzwords that they like to use to make everybody feel like warm and fuzzy inside when in the background, really what they're doing is blocking access to IVF. And it's very difficult to see that and understand it.
thank you. Yes. And we heard this at the end of this session. We heard a big pivot to root cause. They're almost abandoning RM as is it more of a term because they have realized root cause sound is more catchy and it's more mental framework. And you saw that in moms.gov, what was just posted and so on and so forth. So much discussion around root cause. So thank you so much. I really appreciate it.
That I'm gonna just say one thing. Dr. Chen, on one of your slides when you were showing the lab and you talked about the size of the embryo, you cannot see it with the naked eye. I used to tell legislators, if you take your pen and you go like that, a tiny little dot, it's smaller than that, right? Now, remember what I said at the beginning of this call. Health and Human Services has put out their open season for grants for embryo donation, and they're calling embryos children.
Yeah.
Okay, so this is the kind of thing we need to be working about. So we will send out a follow-up email to everybody on our list, invite others to join this committee. Again, Women's Health Advocates, it's free. You'll get on the list. We'll let you know when our next call is and what the topic is. It's going to be on September 3rd, but we'll send you all the details. So you'll always get a follow-up. And I love somebody asked about the link to the HHS. It's a HuffPost article. I'll put that in there if you want to know about, banning IVF in the Republican Party platform in Texas. I can include that as well. But love seeing all of you. You guys are amazing. Dr. Chen, one more big round of applause. Yay!
Thank you.